Good afternoon, everyone. It's really a pleasure to introduce or reintroduce many of you back to Dr. Brian Davis, who is currently a staff physician and a transplant hepatologist in the GI division at the Hunter Holmes Maguire VA downtown here in Richmond. Dr. Davis graduated from UAB and then did his residency at UT Southwestern. And then we were lucky to recruit him here, where he did his fellowship in gastroenterology hepatology, and then on top of that did a transplant hepatology fellowship, which he finished in 2019. And Dr. is a great clinician, has already published really an impressive list of publications, so congratulations on that. And we look forward to your presentation and appreciate your scholarship and your collaboration with the VA and VCU here.
Terrific. Hello, everybody. My name is Lee Johnson. I am one of the chief residents. And before we hear from Dr. Davis, I'm going to give a brief overview of the case presentation. For those who are familiar with CPCs, when we select cases for these conferences in particular, we really try to choose cases that are interesting, that are challenging, and most of all, cases that we think are going to impact the way that we all practice. So over the past several weeks, we've certainly challenged Dr. Davis, and we're so grateful to have him here today. And over the next hour, we will also be challenging all of the listeners. So all of you who have Zoomed in today, please, as you hear this case, I really want you to think about, what if this patient came into your office? So with that, next slide here. The case that we selected today is about a 29-year-old female who presents with rash and vision changes. And we will begin with a case history. So again, 29-year-old female, and she is presenting to an ambulatory setting for evaluation of a chronic, progressive, intermittent rash, as well as vision changes for 1 year. She describes the rash as red and purple. It is located on her hands, ankles, and feet. At first, the rash only appeared after physical exertion, but now it presents more frequently, several days a week. It is not associated with cold exposure, but she does say that sometimes she has localized pain to her fingertips and toes that is constant, throbbing, and gradually resolves within 2 to 3 days. She has also noticed recurrent nail changes a few days after experiencing the rash. She describes the visual changes as seeing bright dots of light for about 15 minutes. Initially, the episode seemed to be triggered by exercise or mental stress, which is similar to the rash. And by now, these are also happening, several times a week, and there's sometimes no inciting event. The visual symptoms are often followed by a headache, and she notices that the rash and these symptoms, the visual ones, are happening at the same time. On review of systems, she reports 1 year of fatigue, 10-pound weight loss over the past 3 months, and she denies fever, chills, and night sweats. In addition to the episodic visual changes, she reports some mild shortness of breath with exertion. However, she denies cough, wheezing, or hemoptysis. Cardiovascular, GI, GU, and MSK review systems are all negative, including no syncope, no nausea, vomiting, no belly pain, no hematuria, no muscle or joint pains or swelling. Again, she's having this episodic fingertip and toe pain associated with the rash, as well as the nail changes. And when you ask her further about these neurologic symptoms, she does report 1 episode of transient right arm and leg weakness that lasted for several seconds. On further history, past medical history, she has migraine-type headaches, exercise-induced asthma, and myopia, for which she has prescription glasses. No surgical history, no family history of cancer or autoimmune diseases, and no known drug allergies. For medications, she had a Mirena IUD that was placed in 2017, and she has an albuterol inhaler that she uses as needed for wheezing. On social history, she occasionally drinks wine. She denies tobacco or illicit drug use. She is a PhD student here in Richmond, and she denies any recent travel outside of Virginia. She is monogamous with her male partner. Her hobbies include rock climbing and mountain biking, and she does explain that she's been less active over the past year due to her symptoms. Moving on to physical exam, her vital signs are normal. You will note, though, the BMI is slightly on the low end, and she is notably thin. Looking here, the rest of the physical exam is really all within normal limits, including a normal fundoscopic exam and a normal neuro exam. When you look at her extremities, particularly her hands, the left hand, there are a few splinter hemorrhages that are noted in the left third and fourth proximal fingernail beds. And now moving on to, I know, the part of the exam that we're most curious about, the skin exam. There is a rash, as you can see in the images here. This is an image of the right foot, and the rash is described as macular erythematous blanchable lesions with a few areas of non-palpable purpura on the right ankle and distal foot diffusely, as well as on the hands diffusely. The finger pads are erythematous, tender, and slightly swollen. And when you look at the palms of the hands, there's a mild mottled appearance. She has no skin ulcers, no nodules, or blisters. Now we're going to move on to the laboratory studies, beginning with serum studies. In the first column here, you can see that the basic metabolic panel as well as the liver function tests are all within normal limits. In the middle column, we have the CPC that is remarkable for a slightly low hemoglobin and hematocrit. The white blood cell count and platelet count are normal in addition to the coags. And in the third column here, TSH, inflammatory markers, CK, and cultures are all normal or negative. For the urine studies, the urinalysis is pretty bland. There's no blood, no protein, and the urine pregnancy test is negative. For the serologies, only one serology stood out as being abnormal here, and that is a slightly elevated ANA. The rest are negative, including rheumatoid factor, anti-Smith, anti-double-stranded DNA, and ANCA, HIV, Hep C and B, and RPR, all negative. Moving on to imaging. Beginning with the electrocardiogram, it showed normal sinus rhythm as well as possible left atrial hypertrophy. The MRI of the brain and chest x-ray were within normal limits. And for surgical pathology, there was a biopsy done of the right ankle and the rash area that we showed you on a few images back, and it was done to the depth of the deep dermis. And together, these findings are those of sparse inflammation and mild dermal edema. The pathologist concluded that these changes are not specific. So that concludes the case presentation. I will remind you all that there is a more detailed written pamphlet that was attached to the email sent out by Thomas Bryan yesterday if you are interested in looking at that. And I will stop sharing and allow Dr. Davis to share his slides and walk us through how he approached this very challenging case.
Sure. So thank you, Lee, for the invitation, and Dr. Syme. Just pull up my slides here. Okay. So yeah, I think these CPC conferences, they were some of my favorite conferences during residency. And I think you learn a lot by the process. I don't have any disclosures other than I don't know the answer. And so my main objectives and goals here, first I just want to start out with defining some basic clinical reasoning terms. I'm not sure how residents or medical students, if this is a formal part of the curriculum or informal part, so I'm going to lay out some terms and I want people to understand what I'm talking about. And then I'm going to apply these terms to today's case, and then I'm going to try to come up with a narrow differential diagnosis and hopefully reach a final answer. And we'll see if I'm right, I guess. So before I get started with the case, one of the first things I did is I went back and read this classic article from Judith Bowen that was published back in 2006. I think if you haven't read it, I would take time out to read it, but it does a great job of explaining how to teach clinical reasoning, and it's very concise and well done. And even though reasoning is very complex and there's a lot of data that you have to look at, this diagram nicely summarizes the process when it comes to clinical reasoning. So you first have the patient's story, and then you take a history. And what I like about this is it goes both directions. You don't just take a history and leave. Sometimes you have to come back and gather more information. And then based on that, you're going to form a problem representation. So this is just essentially the first line in the HPI or the assessment. And this is how you start to generate your hypotheses or differential diagnosis. And from there, you're going to apply that to illness scripts, which I'll define in a minute. And sometimes you have to go back to the patient or to the labs and get more data to further refine the problem representation. And ultimately, based on what matches the problem representation with the illness script, you come up with the diagnosis. And all of this is in the context of knowledge, whether or not you're a third-year medical student or attending, in the context of, is this happening in the clinic or the ICU or the hospital? And the experience, have you seen this case before, or is this something that you've never seen before? And so there's really, over the past few decades, we've started to figure out that with clinical reasoning, there's basically two ways to approach this. And this has been defined in the behavioral economics literature as well by Daniel Kahneman, the famous thinking fast and thinking slow. So this has to do with heuristics, and oftentimes, and you see this a lot in clinic, you see the problem, and usually attendings can make a diagnosis within a few seconds, and as a medical student, I would be very confused what's going on here. But this is just, they're taking the problems and they're applying it to their memories, and they're coming up with a diagnosis. Occasionally, these problems don't fit, and you have to slow down, and what we call thinking slow or type 2 thinking, and that goes back to looking at the problem and trying to ascertain exactly what's going on. So usually attendings kind of do this thinking fast, and medical students do thinking slow. But also what separates experts from novices is the ability to switch, to go back and forth and know when to think fast and when to think slow. So a diagnostic schema is a structured way to look at common problems. So I'm in the transplant world, and so these are common problems that we look at, and we have algorithms essentially that we kind of go through. And it's not just following the algorithms, but it's understanding when patients don't fit the algorithms when it comes to figuring out what problems are. And contrast that with illness scripts, which are frameworks for specific diseases. And again, these are just common things that we see in the transplant world, whether it's rejection, liver failure, cholangitis, or thrombosis. So let's go to the case. So the way I define this initially is that we have a 29-year-old previously healthy female with gradual onset of intermittent, painful, and a progressive rash that was associated with exertional dyspnea and episodic visual disturbances. So the key things here is that she's showing up in clinic and not in the emergency room or in the hospital. So this is not an emergency. And she's essentially previously healthy. So we're dealing with a new clinical problem. The other thing that's interesting is that this is a gradual onset, and so this is progressing. So there's something going on here, that whether or not there's a trigger happening, or it's unclear exactly what it is at this time. But what's also interesting is we have a systemic disease. So instead of there being separate diseases going on, most likely the fact that you have a skin involvement, potential lung involvement with the dyspnea, there's some neuro symptoms, and then the fatigue and the weight loss also indicate that this is a systemic problem. And so the initial diagnosis, differential diagnosis, is very, very long. I mean, these are just some of the things that I came up with initially, but I mean, you could double this list and still go through all of this. So the first goal is to try to narrow down this differential diagnosis. So are there any clues in the HBI? Well, with the rash, it's helpful to note that the location, the fact that this is mostly in the hands and feet, that it's painful instead of non-painful, that helps in delineating what could cause it. There's purple blotching, that's helpful. It improves with elevation, that's interesting. And then no cold exposure, so trying to argue against Raynaud's. And so I'm not sure how specific that is, but that's helpful to note. And so initially, obviously, this is a rash that has to do with the skin, but we're also thinking about blood vessel. Could this be an underlying vasculitis, endocarditis, and malignancy also sometimes present with rashes? The other thing that's notable is the nail bed lesion. So that's very helpful to know that there's a splinter hemorrhaging happening. And so immediately you go from your type 1 thinking, you go to a vasculitis or endocarditis, and that can involve the blood vessel, the blood, the heart. Is there some type of endocarditis happening? The eye floaters, that suggests neurological involvement, and that could, again, be a vasculitis, or perhaps there's intermittent strokes or TIAs happening. And then Dyspnea is non-specific, but that could indicate cardiopulmonary anemia. But again, all of this, if you look at this right column, everything is starting to point towards a vasculitis or some type of systemic disease. And the arm and leg weakness, again, it's transient, it's localized, and this potentially suggests another TIA or some type of vessel is the underlying pathology here. And the review system sort of confirms this. So we've got fatigue, which is very common for systemic diseases, and that makes you think of autoimmune disease, vasculitis, malignancy, anemia, and then the weight loss kind of goes with the fatigue. It's unintentional, which makes me a little bit more concerned for malignancy or an autoimmune disease. And then there are also pertinent negatives that's important to be aware of. So there's no syncope, there's no chest pain, there's no orthopnea, there's no hemoptysis. That would be really concerning. There's no GI issues at all. Oftentimes vasculitis, you have underlying GI issues, but that's not described. And there's no muscle pain or different types of arthritis is not reported either. So other things in the histories that could be a clue. Migraines, I'm not really sure what to make of that. It's very common. I don't know if that's a distractor or that's very common. She's trying to get a PhD. That could be stressful, so I'm not sure what to make of that. Asthma, again, it's very common, but could it predispose to some type of inflammatory or allergy? We don't have surgery or family history to help us. The social history, there's not much. I mean, I'm always interested in alcohol use, but that seems to be pretty minimal. There's no recent travel. She stays in Virginia. She goes rock climbing occasionally. I don't really know if there are exposures to ticks or things like that. Getting a PhD is very stressful. I don't know if I can blame all this on the PhD, but I think that's important, I guess, to note. And then the medication, there are many toxins and drugs and all sorts of things that can cause rashes and neurological signs and symptoms, but she's not taking anything that is known to cause this, and there's no reported drug history either. So now we've kind of narrowed the differential diagnosis at this point into 5 buckets, and you can probably even combine these further. So this vasculitis or connective tissue disease like lupus, endocarditis, it's probably non-infectious, but you can't have non-infectious causes of endocarditis. Cryoglobulinemia, you can link that with the vasculitis, but sometimes that can present at this age. Often there's a trigger for it though. And then malignancy, anytime we have unintentional weight loss, we get concerned about malignancy. Usually with rashes and neurological findings, you sometimes can see that with lymphoma, leukemias, and the liquid type of cancers. So based on those buckets, then you can try to narrow things a little bit further on the physical exam. And again, what's interesting here is that the vitals are unremarkable. So we have normal blood pressure. There's no hypertension. That would suggest potential underlying cardiac disease. There's no hypoxemia, even though she has some dyspnea on exertion. There's no evidence of pneumonia or interstitial lung disease. And her BMI is borderline low. I think that's just something to note with the weight loss. They did a fundoscopic exam, which tells me the eyes are important, but it's normal. So there's no evidence of Roth spots or anything else potentially going on. The cardiac exam, what's important there is that there are no murmurs. So that could make endocarditis less likely. Again, with the pulmonary exam, we have normal oxygen, no crackle. So that probably makes a pulmonary idiopathic or fibrosis process less likely. With vasculitis, you often have arthritis, but there's no evidence of joint tenderness or anything on exam. And then the skin findings, we'll get into in a little more detail, but there are splinter hemorrhages. So that sets off a whole pathway of potential diseases. So that's important to note. And even though there's a history of reported of hemiparesis that was transient, there are no focal deficits on exam. And so with the skin exam, and since this is a presentation of rash, that's what we're going to focus on here. So we have a macular blanchable lesion, and it's non-palpable purpura, and the finger pads are red, tender, and slightly swollen. But there are no nodules, so initially I was thinking maybe these are Osler nodes that we're trying to talk about here, but then they're not nodules being described. And Janeway's lesions are usually look a little bit different than, or they're described differently than this. And then the modeled appearance of the palms, that can, again, suggest an underlying small vessel vasculitis. So the labs are both, I thought, helpful and not helpful, which kind of narrows the differential sum. So the basic, there was nothing that I noticed, but it was just unremarkable. Even though I'm a hepatologist, I don't even have the privilege of looking at the liver enzymes because I didn't get them. So I guess they're normal. The CPC, I mean, she's slightly anemic, but that's pretty common. I wasn't too concerned about that. And the fact that they gave me the eosinophils and that they're normal, I think that's important to note because a lot of vasculitis, a lot of the diseases have elevated eosinophil count, so this was normal. And the UA was unremarkable. We didn't see any evidence of glomerulonephritis. The ANA, so these are positive in a high percentage of the normal healthy population, so I'm not exactly sure what to make about this yet. We have a negative rheumatoid factor, some of the negative autoimmune diseases, but there were several that were not given. I wonder if this was intentional or not, but we don't have a cryoglobulin level, we don't have complement level, we don't have antiphospholipid level. So that may be something that could help narrow things further. And then infection, so it's important to note that HIV was negative, there was no hepatitis C, no hepatitis B, negative syphilis, negative cultures, again, making infective endocarditis much less likely. And the MRI of the brain was also normal, which is important because sometimes vasculitis, you can see evidence of strokes or damage to the brain. And the chest x-ray was unremarkable. So we don't have a CT chest to look at the lung parenchyma, but there's no pleural effusion or pneumonia or anything that would be concerning because sometimes these rheumatologic diseases can present with pleural effusions. And so that's helpful to know that's unremarkable. I'm not sure what to make of this atrial hypertrophy. That could be a false flag, but I just don't really know to make of that without an echocardiogram, which we don't have. Now the skin biopsy is interesting. It's interesting because it's kind of bland. And so what's described is a perivascular lymphocytic infiltrate. The PAS stain was negative. There was dermal edema, and as they said, this was kind of non-specific. So we'll get into what this lymphocytic infiltration means later. So that kind of, just to summarize, this is kind of where I am right now. So we have a previously healthy young female who comes to clinic with episodic painful rash on her hands and feet. She's got splinter hemorrhages, vision changes, some unintentional weight loss, positive ANA, and a benign perivascular lymphocytic infiltration on her skin biopsy. So now it's time to apply some illness scripts. And the first question that should be in the back of everyone's mind is this lupus? And I don't think it's lupus. It's never lupus. So, lupus is a very common disease. We often see it in women at reproductive age, which fits this case. The presentation varies. You can't have constitutional symptoms like this case, but arthritis is pretty common, and that's not reported here at all. And the skin lesions aren't classic. You can get skin lesions as described here that we'll get into, but usually you have the malar butterfly rash, and you can have discoid lupus, and there are these rare chilblains causes that happen associated with temperature changes, which are not being reported. So really the only kind of things that match this illness script with the problem representation are the weight loss, the fatigue, and maybe some chronic skin findings, but they're not classic with findings for lupus. And then when you look at lupus is a systemic disease, which is probably what we're dealing with here. But again, we don't have any hemoptysis. There's no cough, there's no pleuritis. The neuro findings, you can see focal findings in lupus. You can see a vasculitis. But otherwise, again, the CPC is really not consistent with lupus. And the BMP, there's no evidence of kidney injury. That's very common within a new diagnosis of lupus. So, in fact, if you even look at the 1997 ACR criteria, this patient doesn't meet anything here. It's 0. So there's nothing there. And if you look at the European guidelines to make the diagnosis, okay, she gets to enter the criteria because she has a positive ANA. But when you look at all these other criteria they talk about, there's just nothing that she really meets to get to the 10 points to make the diagnosis. So I don't think we can necessarily call this lupus as the unifying diagnosis here. So then the other thing that comes up is this another type of vasculitis? And so there are dozens of different vasculitis. It can get very complicated to try to explain it all, but in general, it's lumped into three main categories: large vessel, medium vessel, and small vessel. Sometimes you can get overlap with medium and small vessel. And so based on our skin findings, most likely we're dealing with a small vessel vasculitis. And again, there are many different types of causes of small vessel vasculitis that are associated with the ANCAs, MPA, or used to be called Wegener's, Church-Strauss, drugs, cryoglobulin, lupus, and then there are all these other diseases that can cause a small vessel vasculitis. But in this case, we have negative ANCAs. The UA is unremarkable. The chest X-ray, there are no infiltrates. The creatinine's normal. The eosinophil count's normal, so Church-Strauss is less likely. We don't have a history of drugs. HSP, more common in kids. We don't really have the exam findings with that. We'll get a little more into cryoglobulinemia. The previous slides, we kind of talked about lupus. Rheumatoid arthritis would be, I mean, she doesn't have arthritis, so I don't see how we can make that diagnosis. Sjogren's syndrome, there was no signs of issues with the eyes or dry mouth. Behçet's disease, again, there were no reported ulcers or smoking or anything like that. Goodpasture syndrome, they usually present pretty sick with hemoptysis and things, and I don't really think that's what's going on. The paraneoplastic syndrome is possible, but we're not really seeing any other signs of lymphoma or leukemia, and there are absolutely no evidence in the clinical exam of any type of IBD. So in terms of her symptoms, I mean, she had some fatigue. The skin findings in small vessel vasculitis, you can see the lower extremities, you can see some purpuric lesions, and you can get positive ANA, but the classic biopsy for a small vessel vasculitis, you have a lot of neutrophils around the vessels, and there were no neutrophils. In fact, there were lymphocytes. So that kind of rules small vessel vasculitis out. And so cryoglobulins kind of fit into this, but since we don't have the cryoglobulins yet, we can't entirely rule that out. There are three main types. There's type 1, which is more monoclonal IgGs, and then you can have polyclonal IgGs or monoclonal IgM, that's type 2, and polyclonal IgM and polyclonal IgG, which is type 3. And usually these are triggered by some underlying disease, right? So in the hepatology world, the classic is hepatitis C, calls it a cryoglobulinemia. You can see this in lupus, rheumatoid arthritis, there's lymphomas can do this. Sometimes even alcoholic liver disease, we see it. And very rarely it's idiopathic. We don't know what causes it. And the skin findings, they can vary, but you can see some papillopurpura as described in this case. You can see some nail fold abnormalities. You can get skin necrosis, vasculopathies. So you can, some of her symptoms do fit cryoglobulinemia, but not all of them. You know, it's very common to present with a peripheral neuropathy, and that's not what's described in this case. So I'm not sure that's entirely what's going on. I suspect if we checked them, they would probably be normal. But there's no real standard way to make this diagnosis. You basically just have to check serum cryoglobulins, and if that's negative, you've probably ruled it out. You do have to be careful in how you check these. There's an appropriate way to check them so you don't get false negatives, false positives. Sometimes you can get a monoclonal gammopathy, so checking a SPEP or UPEP in this case could be helpful. And oftentimes complement is low, and so that could be helpful. I don't think we had that initially. And again, with the pathology, if you biopsy one of these skin lesions, you're going to see the classic vasculitis that has to do with neutrophils or white blood cells. And in this case, we have lymphocytes. You often see eosinophils, which were not seen in this case. And the PAS stain is usually positive, but in this case, it was negative. So that's probably not what's going on here. So let's go back to the problem representation again. And so we still have a previously healthy young female who comes to clinic with this rash and associated neurological findings and skin findings positive ANAs and weight loss. But the biopsy shows this lymphocytic infiltrate. And so what does that actually mean? And a lot of people don't really know what this means. I've never really heard much about this. I had to read up on it. And I thought this article about a decade ago was pretty good, because the immediate reaction might well be, like, what's going on here? And this is associated with really rare conditions. There's no great standard. You can get this disease of the skin called perniciosis or chilblains, which usually has to do with weather, where you can get these nodular, painful ulcers that are associated with cold weather. Sometimes rickettsial disease from ticks can cause this type of vasculitis. You can get these thrombotic arteriitis that can cause it. And then there are these rare syndromes called Deco syndrome and Sneden syndrome that can cause a lymphocytic vasculitis. So in this case, there was no cold weather association. I mean, she goes rock climbing. There are ticks in Virginia, but there's no other real tick exposure. There were no ulcers on exam, but it may be reasonable to check for antiphospholipids or protein C or factor V Leiden. Sometimes that can present like this. And then the lymphocytic thrombophilic arteritis is consistent with can be consistent with the biopsy, and you do see it in women with positive ANA, but you're not going to have systemic signs like you do in this case with neurologic findings. And then let's talk about these two syndromes. So Deco syndrome is a very rare syndrome. No one really knows what causes it. You can have a lymphocytic vasculitis. It is associated with weight loss, but oftentimes you have abdominal pain, which you don't have in this case. And you have these very almost pathognomonic signs where you have this kind of white dot in the center of these rashes, and it shows up on the arms, the trunks, and the legs. And you can get CNS involvement, even hemiparesis or seizures or even cranial nerve palsies. But again, in this case, we're not really seeing that. We don't see abdominal pain. We don't see any, the skin lesions are not consistent with that finding. The lungs, she has dyspnea, but the chest x-ray looked fine. In the skin biopsy, they didn't describe any occlusion of the small blood vessels. So what about Sneden syndrome? So this is another incredibly rare syndrome that's been described in the 60s, and it may be associated with antiphospholipid syndrome. It's more common in females. It often presents in early to middle adulthood. In the skin, you get a rash called Libido racemosa, which is found on the arms and the legs, occasionally the hands and the feet. And this often develops before you develop neurologic symptoms. But the classic diagnosis is made when you start to have neurologic symptoms like vision changes or TIAs or hemiparesis, even cognitive issues, and migraines that can be present for years. And that's associated with this rash finding. And that's kind of what it looks like she has here. I think this rash is Libido racemosa, because you have this normal looking skin around these little tentacle-like prepared lesions. It looks very common to this presentation that I found in the literature. And so the question becomes, does she have the antiphospholipid syndrome? And so this is definitely possible, given that she's describing potential thrombosis. We don't have a pregnancy history, but the way you make this diagnosis is you have to check for the antiphospholipid antibodies, and you have to also have evidence of clinical thrombosis. Either it could be arterial or venous. And if you have those two findings, you can make the diagnosis. There are specific ways that you can check the antibodies that the ISTH gets into in detail, which I'm not going to go into. So I'm not entirely sure what's going on in this case, but the way I would finally summarize this is a previously young healthy female who has Libido racemosa, splinter hemorrhages, and neurological findings. And so what I would say is, if I would test her antiphospholipid antibodies, and if they were positive and they found a thrombosis, then she probably has antiphospholipid syndrome. Maybe this is the index presentation of lupus. If you checked her cryoglobulins and they were elevated, then this could be an idiopathic cryoglobulinemia. If the above tests are negative, I would consider Sneden syndrome, but that's kind of where I landed with this case. So that's sort of all I've got.
Thank you, Dr. Davis. This is, as you have stated several times, a very hard case for, I think, numerous reasons. And, as symptoms that are chronic. So many providers, seen this patient over the course of a year and had a lot of the thoughts that you've shared.
Sure.
So I am going to, we have about 20 minutes left, introduce everybody to Dr. Haim Bardwaj, who is a cardiologist here and is going to walk us through kind of the next steps in this case and present the final diagnosis.
Okay, thank you for that. Can you see my echo pictures and hear me well?
Yes, we can.
Okay, perfect. Thanks for that introduction. Thank you for inviting me here. So I would like to echo what Lee said. This is a very complicated case, took over a year, and you can see all the diagnostic tests that were done. But I did hear Dr. Davis mention echocardiogram. So I wanted to first, whenever I talk about echoes, start with what a normal echo should look like before we talk about this patient's echo. I'm showing one picture to simplify it, but this is what we call an apical picture. It's our 4-chamber view. This is a diagram of how we get the picture. It's basically looking at the heart from the apex going up to the base, and it's flipped around. So this is your left ventricle, this is your right ventricle, this is your right atrium, this is your left atrium, mitral valve and tricuspid valve. So this is a picture that really can help us straight off the bat with any diagnosis that we might have. Okay, so the next picture is going to be this patient's echo. Now, I think it's clear, but I'm going to remind everybody: left ventricle, right atrium, left atrium. So clearly there is something that is not normal in the left atrium, prolapsing into the left ventricle. And it encompasses a majority of that left atrium. Again, the very tough case, but this is what this patient had. So the echo read as an echo density that's attached to the fossa ovalis portion of the interatrial septum, which is where you find these masses in general, that protrudes into the mitral valve and through the mitral valve during diastole. The mitral valve is normal structurally, but is occluded intermittently due to this mass, and there is moderate left atrial dilation, which you would expect. So we also got an MRI for this patient, and this is the patient's MRI, again, just to orient everybody: left ventricle, right ventricle, similar to the 4-chamber view on echo, oriented slightly differently, right atrium and left atrium. And we know we're looking for something in the left atrium. So if you look here closely, you can see there's similar picture, mass in the left atrium, appears to be attached to the interatrial septum that prolapses into the left ventricle intermittently across the mitral valve. So the diagnosis here was a left atrial myxoma. Again, very tough to diagnose, and the reason it is because you can have systemic issues with myxomas. So just a little background: primary cardiac tumors are rare. Metastatic disease is more common. Metastatic involvement of the heart is over 20 times more common than a primary cardiac tumor. So myxomas are the most common primary cardiac benign neoplasm. Most originate in the left atrium, and then the remainder are found in the right atrium. They occur mostly between the 3rd and 6th decade of life and tend to be more common in women. So what's a left atrial myxoma? Well, it's comprised of scattered cells with a mucopolysaccharide stroma. It's typically pedunculated, meaning it has a stalk and it's gelatinous in substance. It can be smooth or it could be villous and have an irregular outside border. And they can vary in size, ranging from 1 to 15 centimeters. I think you can appreciate from our echo that this one was quite a large myxoma. So this is what makes the case interesting. So there's 3 major categories of presentation that are common for patients with myxomas. Cardiac symptoms due to valve obstruction. So they can have signs of mitral stenosis. They can have mitral regurgitation. You can hear that on exam. They can have direct invasion of the myocardium. They can have heart failure. They can have heart block arrhythmias. They can have pericardial effusions. Cardiovascular symptoms are present in 67% of patients with myxomas. Other key thing are neurologic manifestations, and this is caused by systemic embolization, so peripheral or cerebral. So if you remember, for this case, there was question of possible TIAs. There were some neurologic symptoms. And then constitutional or systemic symptoms, the fatigue, shortness of breath, fevers can also present with myxomas. And this patient had fatigue and weight loss. So I think this is very important, as Dr. Davis pointed out, is myxomas have been called the mimicker of systemic vasculitis. And that's why it can be a tough diagnosis. You think, oh, I can do the echo and I find it. But it's getting to the echo that is sometimes tough, and it's because of all these other manifestations, skin manifestations, neuro manifestations. So patients may go see a dermatologist, a neurologist first before they get the echocardiogram and find the myxoma. So what's the embolization of? It's embolization of tumor fragments or associated thrombi. 30% of patients with myxomas have evidence of embolization. 35% of myxomas are friable or villous, and this increases the risk of embolization. The bigger the tumor, the more irregular the tumor surface, the higher the risk of embolization. And so I just want to stress this point, the time from the first onset of symptoms to diagnosis is longer in patients with embolization. And that's because they go see other doctors. If a patient comes in and we listen for a murmur and we hear mitral regurgitation, the first thing they're going to get is an echo. If they complain of chest pain or shortness of breath, the first thing they're going to get is an echo, and that's the definitive diagnosis. However, if they come with splinter hemorrhages or they come with a little bit of neuro issues, floaters in the eyes, they may see other doctors before they reach that doctor who orders the echocardiogram. So management. So management is pretty simple here, prompt resection, and that's because you want to take the tumor out so that you risk the more embolization. And the operative mortality is it's pretty low. It's less than 5%. Most patients do very well with surgery. So then the next common question is, what's the recurrence rate? Well, the recurrence rate can be 2 to 5%. It most often occurs in patients who have multicentric tumors. What that means is they have myxomas in multiple chambers of the heart or multiple areas of one chamber of the heart. So if there are multiple myxomas in the left atrium, that would be a reason that recurrence may occur more commonly. And then there are familial cases. Those are rare, but there are familial cases of myxomas. So the follow-up, so that depends on a couple of things. It depends on recurrent symptoms. If a patient then starts having more neurologic symptoms or starts having more skin manifestations, you're going to want to do an echocardiogram sooner than later. It's also dependent on valvular involvement. If you remember the echo I showed you, it crossed the mitral valve. Sometimes these myxomas can disrupt or destruct the mitral valve. And so you can have mitral regurgitation. And sometimes in these cases, you may have to actually replace or repair the mitral valve. Follow-up in general, we usually will do an annual echocardiogram for at least 4 years. Now, there are case reports of a myxoma coming up 14 years after diagnosis. But in general, if you're going to have recurrence, it'll be within the 4 years of diagnosis. Some studies say you don't have to do an echo. If you do really clear resection, so you take the whole myxoma out and you make sure that in this case there's no leftover myxoma on the interatrial septum, that maybe you shouldn't do echocardiograms, or you don't have to, but we in general do just to make sure. So if you remember what I said for this case, typical myxomas are pedunculated, so they have a stalk, and that stalk is usually attached to the interatrial septum, and they're gelatinous in consistency. And the higher the tumor irregularity, the increased risk of embolization. So this is this patient's myxoma in the OR as soon as it was resected. So you can see this kind of jelly looking appearance. There's some blood clots associated with it. And then you can see this, and this is the stalk. So you often see these stalks attached to the interatrial septum. That's the most common way we will see a myxoma. You can see it's pretty large. It's about, like we said, about 6 centimeters by 3 centimeters. So this patient actually in the OR, because of the stalk and how it affected the interatrial septum, did have to have an intraatrial septum patch placed just to patch up the area where the stalk was located. But luckily, there was no mitral valve involvement, so this patient did not require mitral valve repair or a replacement. It was purely taking the myxoma out and then patching up the interatrial septum where that stalk was attached. So diagnosis is a myxoma, but again, this is a tough diagnosis because it's rare, and it can mimic many systemic diagnoses like Dr. Davis brought up. So vasculitis is a big differential when you have this manifestations that this patient had. stop sharing. That's all I have. So I have to say I'm very impressed with Dr. Davis because this was a very tough case. It took over a year to diagnose, and it was because of the embolization and the going to dermatology, going to the eye doctors, doing that, and then the echo was done and we had our diagnosis.
Yeah, no, that's good because the biopsy was not classic with vasculitis.
Right.
That's where the pathway I went down was like, is this?
Right. No, but like the data shows that people are calling this the mimicker of vasculitis, so it's excellent.
No, that's great. I'm glad they figured it out.
So perhaps we'll just solicit if there's any questions, but I also want to add my congratulations, Dr. Davis. That was a really tough one, and thank you to Lee for doing such a nice presentation of the case and for him for the beautiful images. Maybe I can ask one question. So you did an MRI as well as the echo, beautiful images. Can you share what additional information you get from the MRI and how that's useful?
Oh, that's a great question. So, we can look at the characteristics on echo, and it's a large mass, and it looks like it's attached to interatrial septum. So likely myxoma is higher in a differential, but MRI actually lets you look at the tissue. So on echo, I can say there's a mass, but MRI can try to help you determine, is that mass thrombus? Is it tumor? And so that's why the MRI will help.
You know why the echo was ordered? Was it the EKG findings, or was there concern for endocarditis? Or
yeah, it was the endocarditis. It was the splinter hemorrhages that I think after the full workup was done, there was still not a diagnosis. So the last, one thing that hadn't been done yet was the echo, and so then that was done.
And Dr. Dow is asking him, what might have been heard on the cardiac exam in retrospect?
Great question. So you can hear, like if it's destructed or impacted the mitral valve, you could hear mitral stenosis, you could hear mitral regurgitation. So you would listen for systolic or diastolic murmur at the left lower sternal border sometimes. And I've not heard one, but you can hear what they call a tumor flop, where you can hear it, tumor plop, sorry, where you can hear the tumor kind of going in and out across that mitral valve. But if there is mitral valve, if it's on the left side in the left atrium and there's any impact on the mitral valve, you may hear that as a murmur. And again, if that was heard, she would have likely gotten an echo sooner. And that's why these patients who have those embolization symptoms and manifestations don't get diagnosed as quickly.
Another question in the chat, would a right-sided myxoma have had a similar vasculitis type findings compared to the left atrial?
Excellent question. Not peripherally, you could get some lung findings, but there has been case report where someone has a PFO and a myxoma, and so patent foraminovalle. And so if there's a little hole between the right and the left atrium, and a piece of that comes off and it crosses the left atrium, then yes. But in that case, it's going to be mostly pulmonary.
All right. Lee, do you want to wrap this up? I think it was a great discussion, a great case.
Thank you to just everyone involved over the past several weeks, today, participants, of course, Dr. Davis and Dr. Bardwaj. Thank you for taking the time and energy. I think I certainly learned a lot from writing up this case. I hope that, the people involved and then those listening today also learned. And, if questions linger, as I'm sure they will, certainly with this case, feel free to reach out to me or probably any of us. And really just thank you. And thank you, Dr. Syme, for being here.
Thank you for these CPCs. It's real world medicine and it's challenging sometimes. So, this is why you need a team. Okay. Thank you to everybody. So we'll give everyone back a few minutes and hopefully we can grab lunch before they have to start their afternoon. Thank you.